We're a large referral center for other hospitals, and we're a pretty busy campus. So we're a large volume hospital PE center with 20 PERT activations per month at our main campus. And over the last few years, we've really started to use artificial intelligence to help us manage PE patients. So when we think about the approach to PE, looking at the traditional workflow for PE patients, when a patient is admitted to a hospital or is being evaluated in the ED and a diagnosis of PE is entertained, a CT scan is usually obtained. Once that CAT scan is completed, those completed images are uploaded as a final study to a work list of additional completed CT images that a radiologist then has to interpret. Once that radiologist interprets the scan, if it's positive for a PE, they then have to notify that primary team. Once that primary team is notified, it's up to that primary team to then decide how they want to treat that patient. Do they want to do anticoagulation alone? Should they call a consult? Or if applicable, do they reach out to a pulmonary embolism response team? Now, the use of artificial intelligence or AI has completely changed the traditional workflow for PE. AI is running in the background of every CT scan, and as soon as the CT scan is completed, can detect if a PE is present or absent. If a PE is present, it flags the study as a positive study, so the radiologist can identify that that completed scan has a PE present. And when we look at the traditional workflow, there's actually multiple areas where we can have delays and suboptimal care. The biggest one being is out of the list of completed studies, it's very difficult for a radiologist to know which of those studies has a pertinent finding or not. It's generally completed in a first in, first out process. Using AI, you can have prioritized studies because you now know which of those completed studies are positive for PE. In addition, what AI can do is also detect different thresholds of PE. So for example, at our institution, we have a special alert for any patient that has evidence of right heart strain. And these alerts are sent directly to the pulmonary embolism response team. So as soon as the CAT scan is completed, you now have the reading radiologist aware of the PE, and you have members of the pulmonary embolism response team aware of the PE. And this removes the burden from the primary team of reaching out to consultants or activating a pulmonary embolism response team.
If you're at home, it's 2 o'clock in the morning, you don't have eyes on the patient. You really are relying on someone you may not even know telling you kind of what's going on with this patient. So what PERT has allowed us to do is to sort of be able to respond to these calls a little bit more quickly and efficiently. However, in order to sort of get the information, that remains a challenge, and so it's really dependent on who's calling you. For the PERT consult, you ask them, what's the RV to LV ratio? The what? The RV to who? And so sometimes people don't know what that means. And so, and that may be because, this isn't something that they typically measure and not necessarily know what it means, but it's an important metric for us to help classify the patient into an intermediate or a high risk pulmonary embolism. They may not know necessarily the lab values that we're going to be looking for or the specific vitals that we're interested in. So what this has done really has allowed us to be more efficient in that we're able to get all the information we need fairly quickly.